The high blood pressure we've been talking about is what the textbooks call essential hypertension, meaning that there's no diagnosable cause. And that's been thought to apply to almost everyone with high blood pressure. But research just published in the Medical Journal of Australia has found that what used to be considered a rare cause of high blood pressure, a 1 in 1,000 people, actually occurs in 1 in 7. With significant implications for their treatment. This was David Wyatt's experience. He's talking to Tegan.
I had gone in for a simple bruise, but then found my blood pressure was dangerously high. So the GP I was seeing analysed the blood pressure, and we did a lot of tests and had a lot of trouble getting the blood pressure down. It took about 6 months to find a set of medications that stabilised the high blood pressure. The doctor did a number of tests but said there's nothing obvious that is causing the high blood pressure and I'll be living with it for the rest of my life. It was pretty shocking, particularly when he said basically it's so serious that you could have a stroke or a heart attack at any time.
Tell me about how you came to be involved in the research that June Young's group has been working on.
I was very lucky. I was put into hospital because of arrhythmia, irregular heartbeat.
You were lucky, were you? That sounds terrible.
Yeah, I haven't got to the lucky bit yet. It was at the Monash. While they were looking for the cause of the arrhythmia, they put me in contact with a heart surgeon and a couple of other people. But someone, I don't know who, referred me to the Hudson Institute. And that's when I came in contact with June's group. And they started their own tests, and June suspected the possibility of primary aldosteronism and tested for that, and sure enough, I did have that. I was pleased that something had been found, primary aldosteronism, and because it was treatable, it was good news to me.
How does the medication you're on now compare to what you were using before to manage your blood pressure?
It's a lot less. So there's really only one main pill involved, as opposed to a combination of 3 that I had to take continuously. In my case, I wish we had found that high blood pressure a lot earlier. I just think it's so important. High blood pressure often runs in the family, but too often it's just put down as unknown and a chronic condition.
David Wyatt. So what is primary aldosteronism? How is it diagnosed, and how come so many people have been missed? Dr. June Young is an endocrinologist at the Hudson Institute and Monash Health in Victoria and led a survey in 31 general practices in Melbourne, screening nearly 250 people newly diagnosed with high blood pressure. Welcome to the Health Report, June.
Hi, Norman. Very excited to be here.
We're excited to have you. What is primary aldosteronism?
Well, primary aldosteronism is a bit of a mouthful. It's essentially a hormone cause of high blood pressure. As you said before, I've always been taught that high blood pressure is very rarely due to an underlying root cause. But in primary aldosteronism, the body or the adrenal glands make too much aldosterone, and that's a hormone that tends to keep our salt levels and fluid levels in balance. So you can imagine if you have too much of it, then the body kind of retains salt, retains a lot of fluid, and so the blood pressure goes up. But what's more, aldosterone itself has been shown to cause damage to blood vessels, heart and kidney, with the effect that's above and beyond the effects of high blood pressure. And so the patients with this condition are actually more likely to suffer heart attacks, strokes and kidney failure.
Because it's compounded by the effects of the aldosterone itself. And we'll come back to the treatment, right, because some drugs already on the market do combat part of this system. But we'll come back to that in a minute. Is it genetic? Is it passed down in families?
It can be in the minority of cases, but at the moment it's so underdiagnosed that we don't think we know exactly, what proportion run in families. But certainly in people who have a family history of high blood pressure, it could still be due to their an underlying root cause, such as primary aldosteronism.
And you found that there's a 13-year gap before diagnosis, and often it's too late. Well, not too late, but it's late. We've already got kidney damage, for example.
Yes, that's right. I guess that's one of the reasons that really drove me to pursue this line of research, because in the current guidelines, primary aldosteronism tends to be portrayed sort of as an afterthought, if all else fails, then think about an underlying cause for the high blood pressure. If it's really hard to control despite 4 medications, then think about it. But by that stage, patients have often had high blood pressure for many decades, and they probably already suffered damage that could have been prevented if we test for it early, which is why we did this research. And we asked GPs to test for primary aldosteronism in patients who have not yet been started on medications.
Because the medications could affect the diagnosis, because they might affect the aldosterone.
Well, one reason is that we want to get to it early, so before people have those decades of hypertension. And the second reason, as you said, is that commonly used medications can interfere with the result, the aldosterone test. So just as a personal anecdote, my own father had high blood pressure for about 20-odd years, and it was poorly controlled. He was already taking 4 medications, and yet his initial test for it was negative. But it was only after I changed his medications over to medicines which don't interfere with the aldosterone measurement, then we got the positive result.
Because it was hidden. And it's a simple blood test.
That's right. It was masked. Yes, it is a simple blood test that can be ordered by any GP or any doctor, and it's a very useful test to do.
And in some people, surgery is the treatment and it cures you.
That's right. In about 20 to 30% of people, it's one adrenal gland that's overactive. And in that case, you can actually do surgery, take out that adrenal gland, and the disease is cured. In the majority of patients, they have 2 adrenal glands which are both a bit overactive, making aldosterone.
And you need your adrenal glands.
You need your adrenal glands, so you can't cut both out. And so we have a medicine that's highly effective that specifically blocks the effect of aldosterone. And that medicine's been around for many years.
What medicine is that?
It's called Spironolactone. Some people may know it as a diuretic, a fluid tablet. Some people might take it to help prevent hair loss. So it's used commonly, but not for this particular purpose. And at the moment, if you look at the high blood pressure treatment guidelines, it's considered a 4th-line treatment or 5th-line treatment for high blood pressure. But for a patient who has this disease, it really should be their 1st-line treatment.
Is this something that everybody who's diagnosed with high blood pressure should have? Should everybody have this test? I mean, if it's 1 in 7 and it's treatable and it's a cheap test, that meets the criterion for screening, doesn't it?
Absolutely, and that's what we're working on. Because at the moment, as I mentioned in the guidelines, it comes up too late. Through our research and research from around the world, we have really demonstrated that if you test for it early, you can still find a lot of people with the condition. And that's the ideal time to diagnose it so that you can prevent the harmful effects of aldosterone, prevent the harmful effects of high blood pressure, and get onto a treatment that specifically targets the root cause of the problem.
Now, if you've already got high blood pressure and you're on treatment, is the hallmark that it's been hard to treat? Is that the classic sign of it?
Yes, that's right. So if, just like my dad, if you're already on treatment and your blood pressure is not perfect, then that's definitely a reason to see your GP to discuss testing for this condition. Now, you do have to be careful that we never recommend patients just stop medications themselves in order to get the test. So the GPs can help to switch medications to ones which don't interfere so that the test can be done safely and reliably.
And just finally, there are going to be a lot of people listening to us of all ages. There's plenty of people in their 30s and 40s who've got high blood pressure and need to have it controlled. What are the questions that you should be asking your doctor?
I think the simple question is, do you think there could be an underlying cause for my blood pressure? A hormone cause, perhaps?
Well, most GPs would say, well, no, because they've got this misconception that there's no obvious cause for most high blood pressure.
In that case, it may be helpful to either look up the Hudson website or the Primary Aldosteronism website and bring some printed materials. And hopefully many of the GPs and doctors out there are listening as well and are going to be more receptive to hearing this request from their patients to have the test done. And of course, our job is to actually change the practice guidelines, hypertension management guidelines.
Good luck with it.
So that it becomes more systematically evaluated.
June, thanks for joining us.
Thank you for your time.
Dr. June Young is head of the Endocrine Hypertension Group at the Hudson Institute of Medical Research at Monash University in Melbourne.